A very very warm welcome to this latest edition in our series of events from the Great Minds Project. That we have been doing this since 2020, every 6 months, and it's been a great pleasure to be meeting so many of you that are continuing to support dementia research, and for your interest in where we are in research into this condition. We have a particularly exciting day today because, as you would be aware, there have been some very significant advances in the field, particularly of dementia treatments, which will be coming into the clinical world very soon. So we'll be hearing from some of my colleagues, as well as from somebody living with the condition. So the program for today, we will. I'll start off with a few slides about the Great Minds Project that hopefully many of you are part of, just to give you a sense of why we're doing what we're doing. And then we'll hear from Steve, who's here with his wife. Steve is suffering from he's living with dementia, and so he'll talk about his experience and his views about these new developments that we're seeing in the field. Then we will hear from Dr. Robert Barber, who's based at Newcastle University. He'll talk about how new therapies will work in today's memory clinics. Dr. Chineze Ivenso, who's working in Wales, will be talking about the local opportunities and capabilities available to those of you living in the area. Then we'll have a tea and coffee break, and then we'll have Ollie John from the Royal College of Psychiatrists in Wales, who will be stepping in for Shane Mills, who's the clinical director in the National Collaborative Commissioning Unit of Wales, and he'll talk about how these new therapies, will be commissioned if they're deemed to be cost effective. And then we'll have Dr. Vanessa Raymont, who is based, like me, at the University of Oxford, and she'll be talking about the actual latest scientific developments. And then we'll conclude with a panel Q&A. My name is Ivan Koychev. I'm a senior clinical researcher at the University of Oxford, and I'm a consultant at the NHS, where I'm an old age psychiatrist. So we are here today through the Great Minds Project. Why are we doing this particular piece of research? It's through the advances in the understanding of what dementia is when it starts that we realize that we need to be doing something different about the way that we involve people in research, and it's coming from studies like these, which show that the actual process that leads to what becomes evident to the patients and clinicians as dementia, this loss of thinking, memory abilities, actually starts up to 20 years before first symptoms. When we're talking about Alzheimer's disease, this is a very famous slide, at least in the field, where they picked up people who have the genetic form of Alzheimer's disease, so they've inherited the gene from their parents, and we know they don't have dementia yet, but we know that they will develop it in future, and so they were followed up since their early 20s. And what these researchers in the United States were able to see is that, firstly, the amyloid protein starts to accumulate in the brain about 25 years before people have any symptoms at all. And then gradually you get the other changes, like the increase in the second protein that's relevant to Alzheimer's disease, the tau protein, about 10 to 15 years before first symptoms. And then about 5 years before first symptoms, you start to see changes in the actual structure of the brain. So on some level, this is quite it can be seen as quite scary, that this is really a condition which is is in a way something that it may feel like as if it's destiny for people because it starts so early. But in a sense, especially with the latest development in dementia research, we see that this is actually an opportunity, because there is this long protracted period where the process that leads to Alzheimer's disease is is slowly taking hold, but yet the tissue, the brain tissue, is still healthy. And so if there was a way that we can interfere with that process early on, we could lead to changes. And there's already opportunities out there of how we can potentially do that. This is the one that I'm particularly interested in. It's coming from medications that are already used for other conditions. For example, this is a diabetes drug which is used for the treatment of type 2 diabetes, and because it's been used by people for about 15 years now. When researchers looked into what happens to people who take this sort of drug on a daily basis for their diabetes, they see that there's something very interesting. So about 1.5 years into taking the drug, they start to see that the people who take it start to essentially do not develop dementia at the same rate as people with diabetes who are on a different drug. And then they've taken into animals, and they see that actually this diabetes drug has some protective effects on the nerve tissue. And also they looked into randomized control trials, which were the main studies of these drugs, looking at the effects for diabetes. And they saw that, again, the people who took it rather than this type of drug instead of the dummy pills were the ones were people who were at lower chance of developing dementia. So there are already some of these drugs that we use every day in clinical practice. We know how safe they are, and because of the existing data that we have on what happens to these people, we know that they're associated with lower risk of dementia, which is very, very impressive when you think about that. This is a very significant actual reduction in risk. So what we're doing in Oxford to pursue this particular line of research is that we are taking this particular drug, and we are giving it to people who we know are at risk for Alzheimer's disease because they have the very high levels of amyloid in the brain. And we follow them up for a period of 12 months of them taking this diabetes drug versus a dummy pill. And then we're reading out what happens to the Alzheimer's disease process within these 12 months. So we're really hopeful that with this particularly safe drug, we're going to see that it essentially changes the course of the Alzheimer's disease process that I showed you earlier with these lines of accumulation of nerve damage. But this is a study that is specifically done in people who do not have dementia. So these are people at risk. So how do we actually find who it is that we should be offering these types of studies? Certainly my NHS clinic isn't well positioned to do that. I'm seeing people who already have symptoms. And so in a way, it's coming too late in the process to try these exciting new studies. And this is where the Great Minds Project comes in. The whole philosophy of it was that people have been collecting data, very rich data, on people in the UK for years and years as part of other epidemiological studies, and the data on these individuals just sits in if you like, in data banks. People, of course, analyze them, but with the knowledge we have about dementia, we now know that these data can be extremely useful in actually identifying who it is that's at risk for Alzheimer's disease. So what we've done is we've approached a number of these cohorts, and we're very grateful that a number of them have agreed. Special thanks to Healthwise Wales, who's based here, who have been particularly active, and they've allowed us to essentially reach out to people and ask them the question: are you happy if we contacted you about Alzheimer's disease research and brain health disease research based on this rich data set that these studies have on you? And a great number of you, both in the room and also online, have agreed. We are now over 9,000 active participants who go online and do memory tests online, and some of you have sent us genetic kits. That really gives us a lot of power to understand how the risk develops in aging people, and to be able to pick out the people who would be most likely to benefit from potential new treatments. We also have access to over 58,000 people who have previously said that they're happy to be contacted about future research. So now we're working with this fantastic data resource of 67,000 people with rich data who are keen to participate and further dementia research. and we're already supporting a number of studies by giving them by offering people information about these studies. Now, the things that I mentioned that would really make this database particularly useful is where we have information on people's genetics. So what we have been doing is we have been sending saliva kits through the post, where we just collect a bit of saliva from people, and we've already completed that in 15,000 people. We have also been sending people actigraphs, a bit like Fitbits, just to understand their activity patterns, because we know that relates to dementia. So it's becoming a really useful data set for identifying people at risk. And the next frontier is through accessing blood. Those of you that were at the previous event, certainly in Oxford, would have heard the fantastic advances that are being made. We can now detect the tiniest molecules linked to dementia risk in blood. And so what we have been doing is we have been offering people, certainly in the Great Minds cohort, but also people with the condition, the opportunity to give us blood. And so to even further make our ability to precisely pinpoint risk. And through my colleagues here, Disha and Nishat, we have collected data we have collected blood from 350 people in a very short space of time. We started in November last year, and we have the take-up has been amazing. The original plan was just to do it in Oxford, but then we put it on the National Institute of Health Research as one of the things we are doing, just so that everybody knows. And the take-up has been amazing. We have a pleasure of working with people like Chineze in setting the study here in Newport. But as you can see, we have spread out throughout the UK, and we're actively collecting blood from people, both aging adults, but also people with the condition. If any of these are of interest to you, then there's leaflets outside. If you're not a member of Great Minds, then by all means speak to us, but there's also leaflets showing you how you can join online. It's not particularly complex. And also there's also leaflets about this blood study, which is called the FAST study. So pick up one of those if you would like to be involved. So with that, my introductory spiel is over, and I'd like to move to the really interesting part of today. And the first thing is, we need to always be, when we're thinking about research in dementia, we have to be keeping in our minds the people living with the condition. And we're privileged to have here Steve, and what we'd like to do is to have a few questions posed to him. We have prepared these previously, and do you want to take a stand at the front?
It says, tell us about how you feel about dementia, living with dementia. Tell him what you feel like.
Oof. Stress. I've never done this before.
Go on, man, go on. How do we feel like with you?
Weird. Really weird.
Why?
Because it stops me doing things. Work. I want to work and I can't work.
But,
yeah.
So, but are you all right with it now?
Yes. Yeah, I've come to terms with it. I've got no option. I've got to.
It's hard. Some days he's fine, and other days I feel like saying beam me up Scotty, but it is what it is. You've got a little friend that's with him, and we call his little friend Dementia. So we just go with it. I won't tell you what he says when I says your friend with you, because it's not very nice. Oh, yeah. So it says here now, how did you find out the diagnosing process? We were on holiday, and where we both work, we never see each other. So we went on holiday for our anniversary, and that's when I noticed it. So we sat and we had a chat, didn't we? And then when we came back, then we went over the doctors. Because like I said, he had to accept it first before I could do anything to help him. So we went to the doctors, and then they sent us up to the memory clinic. And I got to be fair, they've been amazing ever since. We go every couple of months, and we're fine. We'd also been accepted on a trial over in Bristol. So with a bit of luck, you never know, we might be able to ease it off a little bit. But it's everything else, didn't it?
Yeah.
But it took him a while to come to terms with it, because he can't drive either. That was the hard bit, wasn't it? Because his job was driving, so he couldn't drive, couldn't do anything then.
It's been
No, yeah, it's about 18 months now where this have actually started. And at first he had the test and about the memory clinic and he was fine. And then a couple of months after then, I noticed it going worse, so we went back up. And then that's when you notice it had deteriorated a bit. But he's fine, and you do your... He gets a bit weird some days, but don't we all? And then it says, how do you feel about the screening for dementia to offer adults? It's a good thing.
Brilliant, yeah, really good.
And he's quite happy to do the trials. We went to do one, but we were on holiday for 3 weeks, and the trial had a date, so we had to be, and we couldn't, so we're just going on another one now, which is on the 24th of November, isn't it?
Yeah, yeah.
And then it says new treatments likely to become available soon. And the thing is, all the treatments that are coming in are to help us. And I think if we can do the treatments, and it helps Steve, it helps me, and it helps other people. And it's just nice to see people trying to help us along the way. And this way important. Well, I've really answered it all. To support dementia, you need to. And we have days where we've had a couple of days last week, haven't we, where he don't know whether he's coming or going. But other days, he's fine.
Don't stop me playing golf, though.
No, he still plays golf. He still plays his golf. He likes his golf. But it's a good job. He likes sport, so it's a good job he likes his sport, and he does it all, doesn't he? And we got some good friends who take him off, and he goes to golf and goes to the football, doesn't he?
Yep.
He goes there, he does his bit. We go on holiday, but we try and stick to the same hotels when we go on holiday, so he knows where he is and what he's doing. But I find when you've had a drink, he's not quite so bad either. I don't know. When you've had a drink, and if he has a drink, he's a lot more sociable. But it's really strange. So we've got friends who says, go on, have another one. And I says, no more, no more.
Fine line.
Yeah, but no, it is hard. It is hard living with it, but it's happening, isn't it? So.
Yep, it is.
And it's just another chapter, and you just turn the page, don't we? And we just carry on,
Get on
don't we
with it,
then?
yeah.
But it do take a long time to accept the fact. I accepted it because I noticed it, but it took you a long time, didn't it, to sort of think there was a problem, because they don't think that there's a problem. They think what they're doing is right. The only thing now, I find he does say things sometimes, and I think, oh, no, please don't say that. But he said to Cheyenne, I got a daughter, well, my granddaughter, my grandson's partner, and it was on the television, and there was a large lady there, and he went, it looks like you. She said, she's thinner than me. She said, thank you very much. I said, you can't say things like that.
I didn't
But
say
they
that.
do. You did.
No. I don't say things like that.
But it happens to me. But they all laugh. I got to be fair, all my grandkids and my thing. And when we went on holiday, there's loads of us, and they usually say to him, Fletch, wrong way, this way. And like the children, when he goes to toilet, he goes up to toilet, and they says, where's Steve gone? And I says, oh, he's just, I'll be going to make sure he's okay. And they just, it's just one of those things you've got to deal with. But it is hard, and I can understand how people find it hard. But we do it, don't we?
Yeah.
Just having lots of holidays now, aren't we?
Yep.
But no, it's fine.
We can open this to. Are you happy
Yeah,
if we take questions from?
No.
Hey, well, I mean, you're the. I'll just ask you to use the microphone because we've got people online.
Hi, I'm a doctor working locally with people living with dementia, and I'm interested in whether you think there are things we could have done better or could do better now.
No, because I think you never know, because you don't notice it, you don't see it, you don't notice it. You just put it to back of your mind. Like sometimes if he had forgotten something, I thought in work he's tired, but it is. But no, I got to be fair. Our doctor, which we went to, and the memory clinic, and yourself, have been marvellous. Like, there's a lot of trials out there, but some people won't try the trials, but they're marvellous. I got to be honest. When we went over to Bristol to the trial, they were amazing. They explained things so much to you, but it's great, you know. And I got to be fair. We got the doctor we see at the memory clinic. She's so excited because we're on a trial. She said, "Oh, should I haven't had a trial?" So yeah, you do marvellous. I got to be honest. You all do, and they've helped us. And if we want any help, I ring, and I got answers straight away, so I can't grumble with them.
Any other questions? There's a microphone coming.
Hi. I just wondered whether you went looking for trials or whether you were just told about
Well,
them.
when we went to the memory clinic, they asked us, would we be willing to do a trial? And we said yes, and they rang us and we just said, yeah, that's fine. I just think if we do it, it don't help us, but it might help somebody else. I think you just got to think it could be a miraculous recovery, but it could sort of be somebody else's sort of chance to not to have it in the way. As I say, you can't get rid of it, but it will help and it could prolong it a lot longer than. So, no, they did. But I will say, when we went to the memory clinic, they said, would you be interested? We said yes, and then we had all the phone calls in to say to go on a trial. So, were you all right with that one, you?
Yeah.
Only thing he didn't like, you had to have a lumbar puncture, so he didn't like that one. That was the only thing he didn't like, wasn't it? Everything else he was fine with, but he was fine. But like I said, it's uncomfortable, but it helps. At the end of the day, it's all for your own good, not for anything else. But you're all right.
Yeah. You keep telling me.
He doesn't say an awful lot. He never used to be this quiet, believe you me.
Okay. Thank you very much for sharing
That's
that.
fine, no.
Appreciate it.
That's fine.
Good.
Was it okay? Thank you. Thank you.
So we are now going to move on to an online talk by Dr. Robert Barber. Dr. Barber works as an old age psychiatrist in Newcastle, and he has an established experience and interest in clinical trials. Over to you, Bob.
Thank you so much for the invitation to be there today. I'm sorry, I work up in Newcastle and just geography got in the way, unfortunately. So it looks like a fantastic day, and what a lovely talk before as well. So very much thank you for the invite. The topic is around new therapies and how they will work in the memory clinics. And I put a big question mark there because I think there are lots of things we do need to understand about this topic. In fact, really, I think, the idea of lots of questions is very much sort of key to this presentation, actually. But I just wanted to start with a disclosure about my own involvement with clinical trials for the past 15 years or so. But also it's probably a bit of a backstory as to why I get involved as a doctor, and it's great to hear the participation of people involved in clinical trials as well. Really, it's just this, I'm sure everybody appreciates today, it's the sheer scale and impact of Alzheimer's disease and others dementias. They are the #1 cause of death, sadly, in the UK. And it's I don't know if the word is sad, but it's kind of disappointing that we just simply don't have any treatments to currently to actually reverse or stop the course of the illness itself. Of course, there's lots of other things which can be done, but actually there's no primary treatment to date, which seems a sad state of affairs, really, given the huge impact of the illness. So I mentioned there was lots and lots of questions, and of course that's what research is trying to address, whether it's about prevention or treatment or better diagnosis. So it's a really exciting time that we may be finding ourselves stepping into a space where there are finally some new treatments. But I think it's fair to say that there are lots of challenges potentially stepping into this space. Lots of things we still need to understand better, lots of unknowns. And there are lots of views about what I'm about to say. So please don't take my views as the only view. There are sort of a rich debate, really, which is needed to take place about the role of these medications. And I'm going to describe a bit about the medication so we can understand some of the dilemmas and challenges in using them potentially. So another way of sort of framing this question really is there's lots of parts of the jigsaw still to be put together when we're understanding Alzheimer's disease, diagnosing Alzheimer's disease and trying to treat it. And there's lots of partnerships really which need to come together to make this work. And maybe another way of visually representing this is this diagram here, that we still haven't really got a complete understanding of the architecture of Alzheimer's disease, the nuts and bolts of it. We've got a blueprint, we've got some diagrams, if you like, some background to how it might work. We're still really trying to piece these things together. And in some ways that was a bit like Alzheimer's drawings from 1906, when what he saw under the microscope when he first recognize the condition. And we still are trying to piece this together to get a really good understanding of what the illness looks like. So I think my starting point to talking about the new treatments is we still don't know. So another one of these question marks, what's going to happen? We're waiting really on the appraisal of the regulators and the funders who will approve these medications to know whether or not they're going to be available in the NHS. So that process, we understand, is taking place over the next year or so, but we still don't know what the outcome will be. So of course we hope the outcome will be that they'll be available potentially, but we just don't know that yet. So this talk really will talk about those new treatments, what we do and what we don't know, and I'm going to draw out some of the impact on the memory clinics and what that might mean for the way we deliver services. I put those in green boxes as we work through this talk, but obviously there'll be time later in the panel for discussion. And I think in the time available, I thought maybe I'd be talking about themes rather than some specific issues, but we can definitely pick up on that. So if we take stock of where we are at the moment, this picture here is a timeline going from 1993 to the current day. As you move along there, you'll see the different medications which have been approved for Alzheimer's disease around the world over the past 30 years. And unfortunately, really, the drugs which we use really date back to the last century, because the evidence which was, and the clinical trials which were taking place were in the 1990s for these drugs. So you may be familiar with the three drugs, donepezil, galantamine, rivastigmine, and then memantine. And that's been the state of affairs for the past 20 or so years. But we're now edging towards a situation where maybe some new drugs are coming around the corner, and I'll talk about those as the main part of the talk. But it's been really difficult to get to this point. So in fact, over 99% of clinical trials up until to this date have actually failed. But this summer, it's been a busy summer. We're in America, the approving authority, so that's called the FDA in the USA, approved lecanemab for use in the United States. So it's now available, and the funders agreed to fund that as well. So if you're living in the United States, this drug is available to you, as I understand. And there was also another drug, a sort of a drug which works in quite a similar way, called donanemab, in the same month, really, in the summer months of July, where the evidence came forward that that drug was also looking highly successful in some respects, or very similar, I should say, to lecanemab. So there's excitement in the air about those drugs. These drugs are quite complex drugs in some respects. They're not, the actual science behind the way these drugs works is not new. There's probably over 100 drugs which work in a similar sort of way, which have been approved. But they're given as they're man-made antibodies, which have been designed to target the underlying disease of Alzheimer's disease, in the hope that that could bring about the improvements we're all looking for. They are complex to use in the sense that lecanemab, for example, is an injection given directly into the blood vessel every 2 weeks, or donanemab would be every month approximately. And these studies lasted for 18 months. So you can see somebody going through a study like this will have had very regular treatments along the way. And it travels to the brain. Only a little bit of the drug actually passes into the brain, perhaps about 1% of what's given. And then the hope is that this then targets the underlying disease mechanisms of Alzheimer's disease. Or I should really frame that question as what we hypothesize to be the underlying disease mechanisms. So, for example, one of the theories about Alzheimer's disease is that there's a buildup of, as it was mentioned in the introduction, actually, buildup of a protein called amyloid, which might build up for many years before actually you develop the symptoms. And these drugs have been designed to find those proteins and then trigger the immune mechanisms of the body to try and remove them from the body. So here's my first green box here. Of course, this will create quite a big challenge for memory clinics to think about how mental health, particularly clinics based in psychiatry and mental health services, will begin to deliver a medication like this. It's very unfamiliar to those services. And if we are going to be delivering a drug which targets amyloid, we need to be able to detect that in the first place. So we'll need a way of detecting that to make sure it's present in the first place, so that the people who receive the drug are receiving it for the right reasons. So we're stepping into this space now about, well, if these drugs are approved, there's lots and lots of questions about how we might think about them being used. What will be the view fundamentally of a person receiving these medications, the patient themselves? That's got to be right at the center of any decisions. What will be the potential demand for this drug, for example? How safe and effective will they be? How are we going to deliver them? Are we ready to deliver them? The answer to that question in a nutshell is probably not yet. And how will services work to do this? How are we going to coordinate services and work together to achieve the delivery of this medication? And quite an appeal to me is, will it change the way we think about Alzheimer's disease? If we have a treatment, will it drive changes in society, change stigma? Will it make the inequalities which come with having sometimes a diagnosis of dementia be addressed, in a sense? So we see these illnesses much more similar to how we think about cancer and so on, that we can really step into the space of thinking about, yes, we really do need to be offering treatments now. And what will the memory clinics of the future have to look like? So this is another way of posing that question, I think. These are sort of two questions I think are quite fundamental to these medications and how memory clinics might have to work. These are sort of personal views to some extent, but I think fundamentally they're going to have to be offered to the right person in the right way at the right time to maximize benefit and minimize risk. And that's going to be a challenge, I think. I'll come back to about that in a minute, but also I think if we're talking about disease modification, I think fundamentally we're going to have to be talking about service modification as well to be able to achieve that. We've got to find a way of diagnosing at an earlier stage and with greater accuracy. So this was also alluded to in the first presentation, the idea, so this is just a diagrammatic, an illustration really of how our understanding of Alzheimer's disease has changed over time. And it's been artificial to draw these circles around this timeline. But as mentioned before, we now understand that the disease has a long period of time when it's building up, maybe 10 to 20 years without any signs or symptoms of that illness. And then gradually the changes emerge, and then eventually perhaps the threshold of a dementia with Alzheimer's disease is reached. And that's really where the services have been kind of located, helping to diagnose and treat people with Alzheimer's disease, which has reached the level of a dementia, so to speak. But what we'll be needing to do is think about how we can use our ability to now diagnose the underlying disease much more earlier and more accurately using the toolkit we have available to us through brain scans, through the lumbar puncture you mentioned, so taking a bit of the spinal fluid and measuring different changes, and hopefully around the corner maybe to be able to do this with blood testing as well. So what we'll have to do is find a way of moving earlier upstream, if you like, to a point where the treatments can identify people who are moving from being not symptomatic to having those very, very early changes with maybe the biomarker changes as well, which will give us the confidence that we are targeting this to the right people at the right time. So it's going to be a drug which will only be probably available for people in that phase of the illness. And these are some of the challenges I think the memory clinics will face about deciding who's going to be eligible, how we're going to diagnose people accurately, making sure that we have the right access to biomarkers. And when I'm talking about biomarkers, these are the tests which are available to investigate dementia, and they're mainly through brain scans, as mentioned, also CSF and through blood tests potentially around the corner. You think very carefully, I know there's a GP in the audience, but very carefully about how we, what the care pathways will look like from primary care GPs into memory clinics and then into the services which might deliver this. We'll need to build capacity and we'll need to work together, because this will really require a lot of different people who haven't necessarily worked together to start working together, I'd imagine. And the reason why earlier and more accurate diagnosis is important, because as we understand Alzheimer's disease more and more, we realize that it's more complex than we had, I don't know if they potentially originally thought, but as we look, it certainly gets more complex. So, for example, although clinically we diagnose people with Alzheimer's disease, we know that probably only about 30% of people with that diagnosis have what you might call pure Alzheimer's disease, so just purely the changes we think of associated with that illness. And other people, the majority of people, will also have other changes, and those other changes may be contributing to the clinical picture as well. So that adds another level of complication here. And also we know that our clinical diagnosis, just by taking signs and symptoms and doing maybe memory tests, aren't accurate enough to be clear about being sure that the people we're diagnosed have the pathology of Alzheimer's disease. So we need to get really much more clever and much greater use of biomarkers, arguably, to be able to do this. But we also know the biomarkers themselves, such as the imaging techniques we need, are not widely available, and so on. So there are lots of issues around the cost, availability, and location of those biomarkers which need to be overcome. Now, I'm sorry this is a slightly busy slide, but I just wanted to present it because it's just a bit of a summary of the original study, the lecanemab study, which was published in the last year, because I wanted to just highlight a few things about this study, because I think the chances are the people who come into this study will be the sorts of people who might be eligible for the study around the corner, is my guess here, is my guess. Because for reasons which will become apparent later in the talk here, there are lots of concerns about the safety of these medications. So this study was run for 18 months. So our evidence about their use really is limited to that window of time. We don't yet know what happens beyond that period of time. Do the advantages of these medications last longer, or do you need to have top-ups? Do you need to have continued treatments, for example? We know that not everybody is going to be eligible for these treatments. So in this study, for example, over 6,000 people were screened, but only 30% of people were eligible to come into the study. There's all sorts of reasons why somebody may not be eligible for a drug like this. Although once in the study, about 80% of people stayed in the study. It was used in people between the ages of 50 to 90. 80% were white. It was only used in people with very early Alzheimer's disease or mild Alzheimer's disease. So if you had more advanced Alzheimer's disease, then you weren't eligible. So there's no evidence for its use in that group of people. And people had to have definite evidence that they had amyloid within the brain, either measured by a scan or measured by the lumbar puncture. And they had 2 of those tests, right at the beginning and 1 at the end, to see if there'd been any change. And importantly, to be in this study, you had 5 MRI scans over the course of the study, once at the beginning to make sure that it was safe and the person was eligible to come in the study, and at least 4 more scans to monitor the safety of these medications. So they are medications which need very close monitoring. So I'll tell you a little bit about what the results were in terms of what the impact was on the biology of the illness, how much of it would potentially the benefits, and what are the risks. Just check my time here. So in terms of what these drugs are aimed to do, is to try and remove the amount of this protein called amyloid, which we think builds up in and around the brain cells and causes them to eventually stop functioning and essentially to die. And what the hope is here is by having these antibodies which travel to the brain, they find the amyloid, and then they trigger the body's immune mechanisms to try and remove that amyloid. And what this graph shows is, for this particular study, is a measure of the amyloid as measured in the brain scans. The top line, the blue line, is the people who were on placebo. And what that shows really over the course of the time is at the bottom. Over the 18 months of the study, the people who'd on this sort of placebo treatment showed no change in their amyloid levels at all over that period of time, maybe slightly increased, but nothing, certainly no reduction. But over the course of the study, people who received lecanemab had a definite, and it was a step-by-step over time improvement or reduction, I should say, in the measure of the amyloid within the brain. So on average, certainly by 18 months, sorry about the spelling error there, the vast majority of people would be at the level, if they had a scan at that point in time, it would look negative, it would look normal in a sense. You wouldn't be able to classify somebody as being amyloid positive. So it definitely does what it sets out to do. And I think that's probably one of the findings which is the least controversial, if you like, about it. And I've just slightly jumped to the donanemab study, and just wanted to illustrate one finding from that study, if that's okay. This is the other monoclonal antibody, which works in a fairly similar way to lecanemab, but this study was conducted in a slightly different way. In the lecanemab study, if you were on the drug, you stayed on the drug for 18 months, right until the end. But with the donanemab study, the way that study was designed was that if your brain scan went from being positive to negative over the course of the study, at that point in time, when it was being measured, you would stop taking donanemab and you would switch to the dummy treatment. So not everybody, in the sense, finished on that drug who started on that drug. So by about 47 weeks, half of the people in that study were able to switch to placebo because the amyloid levels had fallen below that threshold. But the question is, what happens to those people who switched? Because it might give us some indication as to how long do you need this treatment for. And the interesting thing, so this graph, where the top line is the people who had donanemab, sorry, the placebo, and the bottom line is the donanemab, showed that, sorry, the other way around, sorry, that this is a measure of clinical benefit over time. And you can see that the donanemab group did better, but also that benefit continued whether or not they stayed on the drug. So there seems to be some lasting benefit over that 18 months. So it'll be interesting to see when these drugs get funded, whether they'll be funded for 18 months and then be stopped, or whether there'll be some argument about continuing. And that's one of those unknowns at the moment, is about how long do you need this treatment for. So I talked about the biological benefits, now some of the clinical benefits. In a clinical trial, there are lots of different measures which are undertaken to try and evaluate whether or not the drug is beneficial and or safe. And these were the measures which were to see how beneficial it might be. The CDR is a global measure. It's a measure of both memory and cognition, but also how somebody's functioning. And that was the main outcome measure. And there was also these other scales which were being used to look at somebody's functioning, their memory, another measure which was a composite measure of function and memory, and also importantly, quality of life measures. Does it have a meaningful impact on people's quality of life and on carer burden? And all these scales showed a statistical benefit in favour of lecanemab. So there's some confidence potentially lurking there that there is some benefit. But there's been a debate really in the clinical community about the strength of that benefit. Some people feel it as quite a modest, a very small benefit. Other people feel it's a worthwhile benefit. And that debate, to be honest, is still there in the clinical community. But one way of thinking about the benefits could be if you're looking at the amount of slowing. So this doesn't reverse symptoms. It doesn't hold people at the level they're at. It slows the rate of decline. And it slows the rate of decline by about 4 to 6 months approximately. So if you're on the drug, the rate of decline looks to be about half a year slower. And that's going to be a decision really at the end of the day about is the cost of this drug and the risk of this drug beneficial. And in terms of some of the risks, which are important to mention, one of the important risks is that why the MRI scans are needed is that during the course of receiving this treatment, the brain will undergo other changes as well. We talked about the positive changes of removing amyloid, but there are some risks around brain swelling and brain bleeding, and that's some of the statistics there around that. Now, only a small percentage of those people or those people with those changes actually had significant symptoms as a result of that. The majority of these changes are seen on the scans, but not in how people feel. But there are nevertheless some important risks associated with that in a maybe 1, 2, or 3% of people. Infusion reactions can occur as well. They're actually quite common. They're irritations or rashes around the area of the injection. There is also a risk about increased risk of death on this medication. The lecanemab study during the 18 months showed no increased risk, but after the study, that part of the study concluded, people went into an open label, so an extension where everybody got the drug, and there were 3 people who died. And there seems to a concern that the drug might have been associated with that, or at least associated with other risk factors. So those people may have been on other medication or had other risk factors which increase that risk. And certainly the donanemab study, in the course of that 18-month study, that showed a slight excess of risk of death as well. So we certainly need to understand the safety of these medications. And of course, for memory clinics, there's going to be really important considerations about how we monitor that. It looks like some of these risks are much greater depending on somebody's genetic makeup as well. So there may be a need to carry out genetic tests before starting these medications so people can make a judgment themselves about the risks they're willing to take depending on that genetic risk factor. So just my last 2 slides really is really to finish with, again, another question mark really. I think the most important thing about these medications will be the conversations between the patient, their family, and the clinicians about deciding on whether it's the right medication for them at the right time, and whether the risks and the benefits from a personal perspective are the risks that people are, say, happy to take, but have an informed understanding of, so they can move forward clear about what the benefits might be and what the risks might be. That clinical conversation is going to be absolutely central, I think, to any discussion about these medications. It has to be right for the individual. It has to be their decision, ultimately, of course. There is some guidance coming out of America from kind of experts in the field, if you like, about they've termed this the appropriate use recommendations for this medication. And that their guidance to date is to say only really use these medications in the people who are very similar to the clinical trial itself, because that's the evidence base we're most confident about. This is where we know what the benefits might look like and where the risks are best understood. And also with that scrutiny which goes with a clinical trial, with a regular scanning, etc., to keep a close eye on the safety of these medications. So their advice really is to be very careful, yes, to these medications, but keep them targeted to the people who were very similar in characteristics to those people who came into the original lecanemab trial. And that's why I kind of went through that before, in a sense, because these medications certainly won't be for everybody with Alzheimer's disease, and there'll need to be very careful decisions made about their use, I think, assuming they do get funded. So I've tried to give a balanced account there of where we are with these medications, and certainly the hope around the corner is that there will be, safer, more effective treatments potentially, and treatments which will be easier to use. Certainly when you look in the research pipeline, there are lots of different medications which are being tested. Ivan also mentioned about the repurposing medications. So about 25–30% of the pipeline in drugs which are being tested at the moment in Alzheimer's disease come from that category. So drugs which are already being used for other conditions, and can we use them in Alzheimer's disease? The rest are going to be new drugs, but only about 25% of them are looking at drugs which target amyloid or another important protein called tau. There's lots of other mechanisms which are being looked at to see if we can probe and get closer to understanding how we can treat the illness. And it may be that tablets and other ways of giving medications become available. Some people make the comparison between multiple sclerosis and Alzheimer's disease. If we go back to the 1990s, they were neurologists and were grappling with similar sorts of decisions we're grappling with now with Alzheimer's disease when the first drugs came along. But 20 years on, there's been a huge expansion in disease-modifying treatments in that condition, and a huge expansion in the way we develop the services, and you might have hubs which actually deliver those medications. And maybe with Alzheimer's disease, we can see, the most optimistic trajectory is that, we will carry on building on the success story, more research and more opportunities for more treatments the closer we understand the illness. So thank you so much I hope that's been helpful. And thank you for the opportunity to present today.
As we're running slightly behind schedule, I'm going to suggest that we take a couple of questions from the floor, and then there's going to be a 20-minute Q&A once we're done with all the talks, where we'll go through the questions, particularly the one posted online. I can see that there has been some good activity. There's a question in the room.
Thank you. You mentioned about the costs of the nuclear PET scan against the memory clinic diagnosis. Now, I've been done both ways. My past history is of system design and analysis, and my feeling is that the PET scan, the nuclear PET scan, was much, much cheaper than the memory clinic one. I know it looks like, because the tracer costs £800 a throw or something, it might look expensive, but the number of hours spent by psychologists and people reviewing my case, I can't believe that the cost of that would be less than the nuclear PET scan. I know it's difficult to get the tracer up north, but down south there's plenty of opportunity to use it.
Yeah, it's probably important to say the diagnosis of Alzheimer's disease or any form of dementia is both is importantly a clinical assessment to begin with, and then the biomarkers or the tests you can do add degrees of increased confidence in that diagnosis, or increased probability that what you're diagnosing is accurate in a sense, and it allows us to detect some of the underlying changes. But it would be wrong to diagnose Alzheimer's disease just based on a PET scan or a lumbar puncture. It needs the clinical, so they need to work together. I think the CSF or lumbar puncture offers the benefit of being able to test many different biomarkers at the same time, and is cheaper and can be scaled up better than a PET scan. But yeah, PET scans are very accurate as well, but they are much more limited and more expensive. But they always need to be in the context of a clinical evaluation.
There's one question online, well, several questions online, but I'll pick one from Michael. How soon can we realistically bring early screening nationwide?
Oh, it depends what you mean by screening here. I think the blood tests around the corner probably will offer some way of helping to do that. That's the kind of one of the aspirations, I think, and hopes about blood tests. So if you go and see a GP can carry out some early clinical evaluations and then do potentially, I mean, this is speculation, but do blood tests which put people at high risk or higher risk of likely to have Alzheimer's disease, and then those people could be seen in a memory clinic. I don't know if full scale screening will ever be done. I'm not sure. I mean, there are some interesting, sorry, I know we're running short of time, but we've talked about an antibody being given on a regular basis every fortnight, every month. There are some clinical trials around the corner which looks at giving it as a vaccine. So people in their 40s and 50s and giving booster doses and that kind of approach, where you stimulate the immune mechanisms much earlier in the course of the illness to try and preempt some of the changes which are occurring, and maybe to target the amyloid at a much earlier stage. So maybe some more population-based treatments might be around the corner, subject to the evidence being there. And of course, there's lots of debate about how you might reduce Alzheimer's disease by preventative strategies as well in the population level.
One more question from the room, and then...
Sorry, it's me again. But there's so many questions, actually. It'd be interesting, wouldn't it, to evaluate a head-to-head study between the old treatments and the new treatment, and patient and carer acceptability. I'm wondering who's going to deliver a service where you need fortnightly or monthly infusions, where you have to travel to a centre to have them, where you have to have regular scans, all of which cost a lot of money, and where you might die there is that small risk, and whether that's going to reach levels of patient and carer acceptability that equal what we've currently got by delivering the old-fashioned treatments that don't require those things, which just involve a tablet every morning and a regular checkup. And I don't think anyone's really looked at that yet, what patients and carers are going to think about this and whether they're going to go for it or not.
No, absolutely. I think it has to be a patient-centered decision. Has to be. I'm not sure there's any other way of reconciling that. It's an interesting question. I agree. I think there'll be huge, from a personal view, there'll be huge challenges associated with this. But I also find myself thinking that monoclonal antibodies, which is a class of medication, is the fastest growing new treatment around the world. So about a quarter of new medications which are being approved are in that category, and they are widely used around the NHS. And part of me finds myself thinking, why should people with Alzheimer's disease be, I wouldn't say denied, that's wrong, that's too probably emotive, but it's kind of, there should be a bit of there should be some parity within the system to access monoclonal antibodies. Yes, it needs to be very closely monitored, but so do monoclonal antibodies in a lot of other diseases where they're used on much greater scale. So huge challenges, I agree, but parity also maybe needs to come in. I don't know what other people think about that viewpoint.
Thank you very much, Bob. In the interest of time, I'd like to move on to the next talk. I'm aware that we have quite a few questions. I'm sure here in the room, but also online, and we'll ask them during the Q&A at the end of the talks. With that, I'd like to thank you, Bob, and I hope you join us for the Q&A later. The next speaker. The next speaker is Dr. Chineze Ivenso, who's a consultant old age psychiatrist at Aneurin Bevan Hospital Health Board in Newport, Wales, and she's an academic secretary faculty of old age psychiatry at the Royal College of Psychiatrists. I'm very grateful for your time.
Good afternoon, everyone, and I'd like to start by saying I'm delighted at the opportunity I have to present today here in Newport, where I work. I'm going to be presenting about the local opportunities and capabilities that we have here in Newport for diagnosis and management of dementia. I'd also like to say thank you, particularly to Maria and Steve, for taking the time to join us today and sharing your experiences. That's much appreciated. And Bob has led me very nicely into the presentation I'm going to give you today. Getting a diagnosis of dementia is affected by several factors. People's perception about their memory problem, their beliefs, their views, and their feelings can affect the way they have the diagnosis. Even cultural and societal understanding of the emerging memory problem can affect the diagnostic process. I know that health care practitioners, their attitudes and their experiences can also affect the way they diagnose patients, as well as the health facilities available to them. As we know, currently in the UK, memory clinics tend to diagnose dementia at the later part of the illness, when people are in the moderate or severe stages of their illness. Dr. Barber, who presented before me, alluded to this as well. As a result of that late diagnosis, people tend to present too late in the course of their illness to benefit from lifestyle modifications that can help change the trajectory of the illness. Also, we find that as we are hearing now, there may be the possibility of having disease-modifying treatments. And if and when they become available, those treatments are for people who have had the diagnosis early enough. So if I might start by just sharing with you about Aneurin Bevan University Health Board, which is where Newport Memory Clinic is located. We serve a population of about 625,000 people in Southeast Wales. There are 5 boroughs in the health board, and there are 5 memory clinics, Newport being one of them. And a little about Newport. Newport is a city that's blessed with a lot of culture. We have one of 2 transporter bridges in the UK. So that's the Newport Transporter Bridge. We also have the Roman fortress and Baths in Carleon, just round the corner from where I work. And we've been lucky to host presidents as well as golf stars at the Celtic Manor Resort. And our memory clinic is just located at junction 26 of the M4. So just a bit about where we work. But back to what we do in our day job. Our memory clinics across the 5 boroughs receive about 3,000 referrals a year. Newport receives about 900 of these referrals. We noticed that a while ago that patients would come to our clinic presenting with mild memory problems. And then very soon after getting a diagnosis of mild cognitive impairment, we would refer them back to their GPs. 2 or 3 years later, they would return to our clinics with overt dementia. And as a clinical group, we thought we were missing an opportunity to change the trajectory of their illness, so we decided to address the challenge. In order to address this challenge of mild cognitive impairment, we had to make use of several guidelines. The NICE guidelines were updated in 2018. There was recommendation in those guidelines that people who had a difficult to diagnose dementia should be given access to FDG PET scanning or CSF examination in order to make the diagnosis. Here in Wales, the Welsh Government had launched the Dementia Action Plan in 2018. And again, that Dementia Action Plan was encouraging us as clinicians to diagnose dementia as early and as accurately as possible. And there was some funding that was also directed for this purpose. So on the back of that, a team of us in an Iron Bevan University Health Board undertook a pilot study where we tried to test the clinical utility of FDG PET scanning to diagnose dementia. The pilot study was successful because we were able to show that the confidence of clinicians in their diagnosis improved. I know Dr. Pauline Ruth is in the audience today, and she was one of those clinicians, but I would like to say special thanks to Dr. Rui Zeng and also Dr. Patrick Chance, both clinicians that work with me. So following the success of that pilot, we were able to approach the Welsh Health Specialised Services Committee, and we were able to achieve commissioning and funding for FDG PET scanning across all health boards in Wales. And leveraging on that success, we were also able to develop a CSF dementia analysis pathway. I would like to also say that the work we did with the Welsh Health Specialised Services Committee was in a great part enhanced by collaborating with the Royal College of Psychiatrists in Wales. And Ollie John is in the audience. I know he's going to be speaking to yourselves after the break. Of course, we did this in collaboration with other directorates in our health board, which included our radiology colleagues and our neurology colleagues. So we developed 3 new pathways in order to help us diagnose people with Alzheimer's disease at an earlier stage of their disease. These 3 new pathways was FDG PET scan, CSF analysis, and amyloid PET scan pathways. And we based these pathways in our Newport Memory Mild Cognitive Impairment Clinic. Just a little bit about our Newport Pilot Mild Cognitive Impairment Clinic. This clinic is based alongside our Newport Memory Assessment Service, so our normal memory clinic. The aim of the clinic is to accurately diagnose dementia at its earliest stage. And we do this, as Dr. Barber said, through clinical history taking, examination. Sometimes we have to do neuropsychology testing, as well as further investigations. You might wonder, why is this important? Why is it important to diagnose people early? We know that there are lifestyle modifications that may help people change the trajectory of their illness. So when we have given someone a diagnosis within our clinic, we also take the time to see if we can help advice on lifestyle interventions that might be helpful. Most of our referrals come from the GPs. So what kind of patients do we see? We see patients from any age. We also see patients who have a good functional ability and a high score on the memory test. The score on the memory test we've chosen is 83, but it gives us a sense that the person is functioning properly in their daily life. This clinic is run jointly by the psychiatry department in Anna Aaron Bevan University Health Board and the neurology department. Again, I have to say special thanks to Dr. Mark Edwards, who's the specialist registrar who has helped me to run this clinic. Each new patient has a 75-minute slot. In that 75 minutes, we try to take a comprehensive history and undertake a medication review. The comprehensive history is that we try to understand the nature of the memory problem the patient is presenting with. We also take time to understand the risk factors that the patient may have that may make them more predisposed to having a dementia. So for instance, we look out for people who have poor hearing, and then we refer them on to audiology services. We look out for people who might have a sleep apnea, so they present with symptoms of sleep problems. We're lucky to have a sleep clinic within our health board. We refer them on. Some people might drink alcohol in excess or take illicit drugs, and that may be affecting their memory, and we refer them to the drug and alcohol service. As psychiatrists, we also look out for people who have depression and anxiety because that's treatable as well, and it can affect the memory. Some patients come to us with polypharmacy. They have too many medication in the list of medication they have, and some of the medication they have is actually affecting their memory, so there's an anticholinergic burden to that medication. So for those patients, we refer on to the GP for a review of medication. But most important, we look at people's cardiovascular risk factors because we know that what is good for the heart is good for the brain. So we particularly look out for people who are hypertensive, poor control of their diabetes, or people who have high cholesterol. Because by trying to manage those conditions, the memory problem is better controlled. So again, we seek for the GP's assistance to manage it. We take a mental state examination, and if indicated, do a focused neurological examination. Once we've done all these things, then we discuss the results of memory tests that we do for patients and look at CT scan results as well. Sometimes we're able to make a diagnosis at that point, but sometimes we're not. And then we have to seek to do other investigations, which would include neuropsychology testing, imaging, FDG PET scan, amyloid PET scan, and CSF examination. The CSF, we're looking for the proteins that are implicated in Alzheimer's disease. So once the patient receives their diagnosis, we give enough information about the illness we think they have. Again, like I suggested, we give some advice about useful lifestyle interventions. So for instance, we advise patients that they could take up a Mediterranean diet because that would help with the memory. We also advise patients to try and have exercise. The right amount of exercise is often recommended that maybe people can do 4 hours of exercise, maybe a week. And maybe it's the type of exercise that makes the person a bit exerting of themselves. Also, we ask patients to try and look for activities that will keep their brain stimulated. So we're lucky in Newport. We have a home-based memory rehabilitation service, which is led by our allied health colleagues, our OT colleagues. I have 2 OT colleagues in the room, Vanessa Raymont and Vicky Richards. We're lucky in Anna Aaron Bevan University Health Board. Our OT colleagues are able to try and give patients memory strategies and memory aids that they can learn at a very early stage of their illness so that they take it forward as a more habit-forming and routine-forming activity as the illness progresses. So we also have the mental health input we give, which is we treat depression and anxiety and develop a follow-up plan for the patient depending on their needs. We do encourage patients to join dementia research. And then if we have access to research projects like Ivan mentioned at the beginning, the FAST study, we encourage patients to take part in that. We're grateful to our colleagues in Anairon Bevan Research and Development Department because they help us to carry on this clinical research, and also Healthcare Research Wales for the support they give us as well. So I thought I might bring a patient story to yourselves today, because sometimes when we hear about how our services has affected or impacted patients, maybe it's easier to understand. So today I'd like to share with you about a 59-year-old employed shop manager who came to our service. Initially was referred in November 2019 by the GP. The patient presented with subjective memory problems and was independent in all activities of daily living. So they had a very high cognitive score, so a memory test score of 92 out of 100. The CT scan that was done at the time was reported as normal. At that time, our patient was reassured and discharged with a diagnosis of a mild cognitive impairment, but we said, if the memory problem got worse, please come back. So in 2021, the same patient was re-referred back because the memory problems had persisted. And the patient was concerned about the memory problems, but the patient was still able to carry out all activities of daily living. The memory test scores had dropped, but not so much. It was still 87 out of 100. The CT scan done at that time did show some shrinkage in some parts of the brain. The patient was sent for a neuropsychology test, and that test showed that the executive function was good. That there were problems in the executive function, and there was problems in the processing speed as well as the visual perception parts of the memory. Then we sent the patient for an FDG PET scan of the brain. So the FDG PET scan showed that there were parts of the brain that weren't functioning as they should, and the pattern of the lack of function was suggestive of Alzheimer's disease. I haven't gone into the details of the exact parts of the brain, but as you can see, there was some hypometabolism in certain aspects of the brain. We were lucky enough to send our patient for a lumbar puncture. So that's where we took the cerebrospinal fluid and we looked at the proteins that have previously been mentioned to see what the levels were in the cerebrospinal fluid. And we found that the amyloid ratio was low. We found that the phosphorylated tau was high and the total tau was high. Again, this pattern is highly suggestive of Alzheimer's disease. So in combination with the clinical history we've taken and the memory tests we've done, the neuropsychology testing, and all the investigations, we were able to give the patient a diagnosis of a mild cognitive impairment due to early Alzheimer's disease. And the patient is being followed up by our memory clinic nurse. What was the impact on this patient's life? Our patient was still working at the time he came to our clinic, and he needed to have adjustments within his work because of the diagnosis. And he was able to have discussions with the employers about the adjustments that were needed for her at work. Our patient was referred to the Alzheimer's Integrated Support Team and Age Camry because there were benefits that the patient could access. The patient was given some advice about power of attorney and how to achieve that, because sometimes people want a chance to be able to plan for the future. So being able to diagnose people early gives them a chance to plan for the future. In addition, our patient was given access to join dementia research and advice about lifestyle modifications that were needed. So we cannot do the work we do in our memory clinic in Newport without our partners. We do as much as we can, but we have partners who help us to help our patients and their carers live better with dementia. The next two slides I have will show contact details and names of our partners. I would like to highlight that within Anairon Bevan University Health Board, we have a public engagement team. Amanda Went is in the room, maybe in the break. For those of you who are here with Sonia Foley, you could have a discussion with them about how yourselves as patients and carers can get involved with how we design our services within Anairon Bevan University Health Board. we would like to hear your views on this. There are other facilities that are accessible here in Newport. I've already mentioned the home-based memory rehabilitation service, which is being led by our occupational therapists, and Jessica Moss is the lead, and I have her contact details there. I'd like to say thank you to Vanessa Raymont for helping with these 2 slides, but maybe when you have when you're able to look at the slides, you'll be able to take some of the information about where to go. And then I'll end my presentation because I think Dr. Barber has said it all in terms of when we look ahead, there are new treatments coming round the horizon. These treatments do slow cognitive decline. They do come with side effects. But what we do need to think about is how we modernize our memory clinics so that we can give patients a chance to have an early, accurate diagnosis, not only to give them a chance if they wanted the treatment to have it, but also to give patients a chance to have lifestyle modifications that can improve the trajectory of their illness. Thank you.
Many thanks. I think we have a couple of time for a couple of questions, and then we'll go for a coffee break. We're running slightly behind schedule. Simon, you look like a man that has a question.
In the room. Thanks, Chineze. How will memory clinics be located away from mental health services, such as going into main general hospitals for biomarker collections and treatments?
Thanks for that question. I suppose currently we have our memory clinic, our mild cognitive impairment clinic, located within our mental health service. The biomarker tests I spoke about, so the FDG PET scan and the amyloid PET scan, they're currently being undertaken in the University Hospital of Wales, so a general hospital. And the CSF analysis is being done in another general hospital in the Newport area, the Royal Gwent Hospital. I think we would like to send our patients to the best place for them to have these biomarker tests done, and that would be in the general hospitals, but we could then take the results and bring the picture together for the patient.
If I can ask you a question, Chineze. So you're doing these biomarker tests at the stage where people have very mild symptoms, which I'm fully supportive of, and I think you're actually way ahead a lot of other clinics I know around the country. But in a sense, I guess that poses an interesting interaction when you feed back the diagnosis, because clinically this person would qualify, for example, for having a diagnosis of mild cognitive impairment, and yet on the biomarker tests you would know that this is an Alzheimer's disease process. So how do you communicate this? Because technically, the current understanding of that we have is that we would call that mild cognitive impairment due to Alzheimer's disease. But in a way, I think in popular speak, if you like, Alzheimer's disease is synonymous with Alzheimer's dementia, even though that we now recognize that there's a difference between the two. So how do you navigate that?
Thank you, Ivan. That's a very interesting question. And it's something I've had to start learning to navigate. So my discussion with patients before I send them for the test goes along the lines of what we've heard today. I explain to them that there's a long lead up to Alzheimer's disease becoming a dementia. So I try to explain to them that actually that there is a difference between having Alzheimer's disease and having Alzheimer's dementia. So that by the time I get back the results that show that the person is in the earlier stages of the illness, I'm able to explain to them that actually what they have is Alzheimer's disease and not the dementia. And then I say, we don't know where along the 0 to 20 years you may be on. But what's important is that we try and do what we can to slow this down, which would include good diet, exercise, and keeping the mind stimulated.
That's fantastic. Well, credit to you and your team. I think you've done a fantastic work. Our next speaker is Ollie Joan. He is a manager for the Royal College of Psychiatrists in Wales, and he's stepping in to talk about the commissioning side of the new treatments. Ollie, over to you.
Pnawn da pawb. Good afternoon, everyone, and thanks Ivan, thanks Simon as well for putting this all together. It's a fantastic event, fantastic programme. My name is Ollie John. I'm the manager of the Royal College of Psychiatrists in Wales. I've had the pleasure of working with the previous speaker, Chineze, for a number of years, and her presentations made my short couple of minutes infinitely easier. So I'm stepping in to talk a little bit about clinical commissioning in Wales, where it currently sits, but having that description about the strategy from Chineze and also the example with FDG PET scan into aid dementia diagnosis is something I'll probably refer to in the next couple of minutes. So what I would say in Wales, it is a national priority. We do have a national strategy, a national dementia action plan. We have a number of agencies involved in implementing that work, from Improvement Cymru, a formation of an NHS executive, but also a number of professional groups involved in that work too. And that's what makes work like Dementia Platforms UK, sessions like programs like the Great Minds programme, really, really important, because when we think about commissioning, it's about what's evidence-based, but also what can be scaled up in Wales as well. And that's the really exciting element we feel really strongly about, is actually in terms of population of Wales, in terms of numbers of health boards, we need to start thinking about, do we have the infrastructure in-house to really scale this work up? And I think the PET scanning example that Chineze made to aid dementia diagnosis is really, really relevant here, because within that work, there's only a certain number of professional groups, that people who can diagnose, who need to be pulled together to really understand actually how can we make this pathway really, really clear to patients, to carers, and to other clinical groups as well. And I think looking at that model, it's something that we feel confident in terms of, can we replicate some of that learning around some of the other things which have been mentioned by Dr. Barber and by Chineze as well, around things like the MCI clinic, amyloid PET scanning, CSF analysis as well. And I think that's what's really exciting, is that actually potentially there's a suite of things either now or on the horizon or emerging, but we really need to understand how we can make this available. And I think the other point I'm really keen to get across as well is around equity across Wales as well. So there's really, really good work going on in Gwent, and you know that the health board have to be commended alongside a number of people working in and around the health board too. But it's how can we make this available across Wales in a way which is actually going to make it really, really accessible and equitable for patients and for carers too. So what I'm just a couple of last things from me, and you can tell I've not prepared any slides or anything, so forgive me, is that what we're really keen as a college as well is to bring that clinical voice into the commissioning cycle too. So we very recently started working with a national collaborative commissioning unit to ensure that takes place, because what we're really conscious of is that when we're looking at national specifications for new treatments, for emerging therapies, is that actually local implementation is really, really important as well. And we've seen that through things like the 111 Press 2 service for mental health, which you may have seen recently been implemented across Wales and has been constantly evaluated, but is being scaled up in such a way where it's a national specification, but working upon local implementation and expertise as well. And we see similar crossovers with approaches with looking at kind of new and emerging therapies and treatments too. So I think there is cause for optimism in Wales. I think there's a lot of interest, a lot of people who are keen and embedded and involved in this work. But hopefully what I was keen to get across today was that actually there is opportunities with some of the things which are being developed across health boards to look at them and to think about how they can be scaled up in an equitable way, but in a way which is actually going to be really timely for patients and for carers. So alongside all the presentations about clinical and research and expertise, you know, can we match that with actual pathways which are going to be efficient and effective, and have we got that link with primary care, link with the third sector, voluntary sector, the amazing work that Chineze identified that AHPs do in this space as well. So thank you. I hope that was helpful.
Thank you.
Brilliant. Thank you very much. Ollie will be at the panel in about 20 minutes. So any questions we can also ask then. And we're moving on to the last formal talk of the afternoon. This is going to be my colleague, Dr. Vanessa Raymont. She's a senior clinical researcher at the University of Oxford. Her clinical and research interests are in traumatic brain injury, memory disorders, and dementia, as well as clinical trials in cognitive impairment. I work with Vanessa. She is the chief investigator of the Deep and Frequent Phenotyping Study, and also an associate director of Dementias Platform UK, where she leads the trial delivery framework. Vanessa, I can see you're online, so we're very happy to have you.
So thanks for the introduction, Ivan, and thanks very much for inviting me to be here. Sorry I couldn't be with you in person, but nevertheless, I've got a lot that hopefully I can cover in the next 20 minutes or so. I'm hoping I can touch on a few other scientific developments. I know you will have heard about quite a lot already from Bob Barber in terms of new drugs, from Chineze in terms of clinical pathway developments locally. So I'm going to try and pull that a little bit together with some other information about where we are with things like biomarkers. I saw there were a couple of questions around that in the chat. Suffice to say, I'm an old age psychiatrist and have been working in this field for about 30 years. And I think we're at a really, really exciting time in terms of developments around dementia. And for the first time, as Bob described, we're at a point where we may have disease-modifying drugs for Alzheimer's disease, but also there's an awful lot going on in terms of how we detect some of the disorders as well. So I think we are at a very exciting time, and a time when we are able to make real significant difference for patients and families. So I'm going to start off with a few statistics that you may well be quite familiar with. I think we all know extremely well that dementia is seen as one of the greatest global healthcare crises of current times. It affects almost 1 million people across the UK, 50 million people worldwide, but that is forecast to triple by 2050. On top of that, to date, most services have focused their energies on identifying people with dementia rather than people with earlier disease. And it's estimated there could be as many as 20 million people over the age of 55 with mild cognitive impairment, so earlier disease, across the EU. So we've been aware for a while that services needed to start to shift, and that would match scientific developments. And you can see listed here a few of the international initiatives that have been developed over the last few years. So back in 2017, something called the Global Coalition on Aging and Alzheimer's Disease International developed something called the Innovation Readiness Index. So looking at how countries were getting prepared for delivering new scientific innovations. The World Health Organization in 2018 developed a guide for countries to develop their own dementia plans. And then a really big piece of scientific literature that came out in 2020 was a Lancet paper which identified 12 modifiable risk factors that could account for up to 40% of dementias. So really emphasizing that there was an awful lot that we could do now to try and prevent progression into dementia in the future. And then in 2021, something called the Davos Alzheimer's Collaborative launched their healthcare system preparedness project. So there's been a lot going on the last few years, saying we need to change how we manage clinical pathways, as I said, to manage all these innovations and get them to patients as quickly as we can. But I would say at the moment, there's still quite an emphasis on dementia, obviously a great area of clinical need, but we also need to think about how we identify early disease as effectively as possible. And because we have these disease-modifying drugs on the horizon now, management of dementia is evolving, but we need to think, when is that happening? When are we going to identify people? Who's going to do it? Where are those identifications going to happen? Part of the reason why it has been taken so very long to develop any drugs that tackle things like Alzheimer's disease is because these pathologies are very complicated. So this slide just even tries to highlight some of those processes. And you will all, I'm sure, have heard of things like the buildup of amyloid plaques and tangles of tau in the brain. But you can see on the right-hand side here a list of a whole load of other pathologies that go on. So inflammation, oxidative stress, a whole load of other things that affect the brain that mean if you target one of these in Alzheimer's disease, it may not necessarily prevent the disease progressing. You may also have seen these curves. These are very famous curves called Jack curves after the author of the paper in which they were first produced. What they emphasize is that we now know that particularly Alzheimer's disease probably starts in the brain decades before we actually develop clinical symptoms like memory problems. So you can see here those curves when you are cognitively normal in midlife, you're still starting to get a buildup of things like amyloid and tau in the brain. And this is the period that presents the opportunity for what we would call secondary prevention. So when we know that things like Alzheimer's disease are present in the brain, but at this point you haven't started to develop significant memory symptoms. So that's an opportunity for treatment. Another opportunity, which ultimately we hope we'll all be aiming for, is primary prevention. So is there a way we can actually stop people developing things like Alzheimer's disease in the first place? The other thing that we're becoming increasingly aware of is that the buildup of things like amyloid in the brain in Alzheimer's disease, and also as we age, can be predictable, but it develops at different ages. And this probably feeds into some of the recent things that have come out in the literature around the impact of exercise or lack of exercise. It probably isn't just to do with the process of early Alzheimer's disease, but also how normal proteins in the brain like amyloid change as we age. And it's not just the amyloid. So what this diagram demonstrates is that all those other processes that I mentioned that we know take place in Alzheimer's disease probably also develop at different rates at different ages during our lifespan. So on the left-hand side of this diagram, you can see some of those listed. So build-up of amyloid at the top, cortisol, which is a hormone we know that's important in terms of development of Alzheimer's disease, inflammation, vascular, so blood vessel changes and build-up of things like tau and so on. What this emphasizes, as I said, is that these things probably happen at different rates as we age. If you then look at Alzheimer's disease on top, because as I said, some of these proteins are normal proteins in the brain, things like amyloid and tau, you just add more complexity into the mix. So if you are somebody who's gradually going through middle age into later life, and you add Alzheimer's disease on top, changes in these individual proteins and issues like vascular disease will also vary as you age. So if you're going to produce a drug that targets amyloid, for instance, it may be that's going to have maximal impact later in life. But if you wanted to produce a drug that's going to target amyloid and vascular changes, actually that may be best targeted at somebody in their 50s or 60s. The other thing, as I said, that came out of this paper, this landmark paper published in 2020, was the real impact that risk factors had on the likelihood of things like Alzheimer's disease progressing. And another thing we're becoming mindful of the fact that these risk factors also probably have their maximal impact at certain ages. So things like your genes certainly have an effect on your risk for developing Alzheimer's disease, but things like diet, obesity, hypertension may have maximal impact in kind of middle age. Things like diabetes, vascular disease may have more of a effect on your risk levels later in life. Similarly, we know there are several protective factors that reduce the likelihood of progression of things like Alzheimer's disease, like cognitive and social activity, levels of education that boost your brain and cognitive reserve. And we're really only just starting to understand whether those have maximal impact at certain points in the age span, so that ultimately you could possibly balance in a kind of personalized risk management plan how you reduce somebody's risk factors and how you try and optimize their protective factors. So I think we're genuinely at a point now where in the next couple of years, we are going to be giving individuals the probability of developing dementia or a neurodegenerative disease rather than just a diagnosis. And this would be based on changes in biomarkers, changes in your cognition, and ultimately whether you're more likely to progress into an actual disorder like dementia. So how do we do this? Because of course, the underlying problem is if we are going to identify people earlier in the disease pathway and carry out secondary prevention, but this is before they start to develop significant memory problems, how do we identify people? Well, as I said, one of the things is to look at people who have higher levels of risk factors, whether those are fixed, so things like your genes, or modifiable things like diet or obesity. We're probably going to be looking for people that have a particular cognitive profile, so maybe very subtle changes in their cognition rather than actual symptoms. And the other thing that will become key are biomarkers. And the question that we're all asking at the moment is whether we can develop an accurate prediction score that would pull all of this information together and identify people most at risk. So once you've identified people, obviously then what we would hope to be doing is to tailor treatment. And this is where those new drugs that are coming along very, very quickly are key, because we can certainly reduce risk factors and we can encourage people to enhance their protective factors. But if we have the opportunity for disease modification through drugs, obviously that's massive. What we think will probably happen in the future is that you will receive a combination of treatments of both disease-modifying drugs and drugs that manage the symptoms of dementia. But then how do we measure success? Because again, if we're going to give these drugs to people with very early disease who don't have significant memory problems, how do you know if they're getting better? Well, there could be a shift in their cognitive profile, but what I think we'll really be looking at is changing these biomarkers again, and ultimately whether over time their risk of developing dementia decreases. So I'm going to talk a little bit about biomarkers. I know that you've heard about this already. Chineze talked about FDG PET in her clinical service, and I know Robert Barber touched a little on these in his talk. But basically, just to reiterate, a biomarker is anything that is a measurable substance or characteristic that will indicate disease. So it could be as simple as taking blood pressure, it could be looking at your genes, at proteins in the brain, or using things like imaging to quantify those things. And in terms of Alzheimer's disease, back in 2011, two big organizations in the US, the National Institute of Aging and the Alzheimer's Association, created a framework for us to think about biomarkers in Alzheimer's disease. And it's called the ATN criteria for amyloid, tau, and neurodegeneration. And again, some of this you probably already touched on today, but these are how we try and measure those ATN criteria currently. So you will have heard a little bit about CSF testing and lumbar punctures, and at the moment, that's one of the cornerstones of how we assess amyloid and tau in the brain. The problem, of course, is that any form of lumbar puncture is relatively invasive and therefore difficult to be able to implement at scale, and a really difficult thing to ask patients to have to do in a lot of cases. We can measure amyloid directly in the brain now with PET scans, and there are a number now of licensed tracers that allow us to do that. But again, the issue with those is they're quite expensive, and you need a particular scanner to do those scans, so that means there's limited availability. We now actually also have tracers that enable us to look at tau in the brain, and that's quite exciting because the level of tau in the brain appears to correlate much more closely with people's cognitive impairment and functional impairment than levels of amyloid. Chineze, I know, has talked about FDG PET and the role of that. FDG PET looks at brain metabolism and the levels of blood flow in the brain. Again, it gives us an indication of brain activity. But again, it's a PET scan, so it's relatively expensive and limited in how available it is. And then the other thing that we tend to do more commonly as a biomarker at the moment in dementia is either MRI or CT structural scans, where we're looking for atrophy, shrinkage of the brain, which can be a core feature of development and progression of Alzheimer's disease. But this is a relatively late event compared to those early biomarkers that you saw on the curves of changes in amyloid and tau. So we've been looking for a while for things that are more accessible and scalable in order to measure these changes. And at this point, things have really shifted because we're at a point where a lot of blood tests that have been developed seem to correlate really well with amyloid PET scan results and also with cognitive change. And this diagram kind of summarizes where we are. So I'm just going to talk you through it because there's a lot of stuff on this slide. We've been looking at potential biomarkers with CSF tests back into the 90s. And you can see on the top of this diagram in 2011, that's where this ATN criteria was first set up. And it's not just about the amyloid, the tau, and things that indicate levels of neurodegeneration like brain scans. You can see on the left-hand side of this picture, astrocytes and microglia. These are two cells in the brain that are involved probably in some level in inflammation and management of inflammation. And it looks like by looking at the functioning of these cells, we've also identified biomarkers like something called GFAP, which allows us to measure inflammation in the brain. That could be another key way of assessing where people are on that timeline of Alzheimer's progressing. But you can see on the right-hand side of this diagram, we really now are at a point where we are able to measure a lot of these via blood. And a lot of these are in early development. So as I said, things like GFAP and something called neurofilament light that looks at neurodegeneration more generally. But this is a very significant change in how we can use biomarkers to detect people who would benefit from changes in management. But what are the issues? Well, In terms of measuring amyloid, we're now realizing that there's different types of amyloid, and probably a ratio of amyloid is the best way to detect early Alzheimer's disease. And in fact, there is a commercially available test now called Precivity:AD. It's available in the US, that looks at this amyloid ratio. They also look at your ApoE status, so one of the key genetic markers of with Alzheimer's disease, and age. And that seems to correlate extremely well with the likelihood of you having a positive amyloid PET scan. So we are at the point where we feel that a lot of these blood tests are really viable and could be used in clinical practice. There are also blood tests that have been developed that look to be very favorable for measuring tau. And particularly if you put this together with those amyloid measurements, that seems to be particularly useful in picking up people in the early stages of disease. And then as I mentioned already, there are other blood tests already in development to look at things like inflammation and neurodegeneration. And they may be particularly useful at identifying people that are more prone to a faster level of decline, and again, in the early stages. But, and this is a big but, we lack a certain amount of real-world data. So most of the research that has been done to develop the blood biomarkers lack people who are more elderly, people who have particular risk factors and what we call the comorbidities, so other things in their medical history that make them more likely to develop dementia, and more ethnically diverse groups. So the data so far shows that some of these blood tests certainly perform inconsistently in certain ethnic groups. Things like the amyloid ratio and tau levels seem to increase with age and with cardiovascular disease, and decrease with obesity. And it's unclear what the effect of sex is. So different studies have shown different results in males and females. So although we're close to these blood biomarkers being useful in clinical practice, we still need to get a lot more data to really understand how they can work across the entire population. So what are the good things about blood biomarkers? As I said at the start, I think this is a tremendously exciting time, and blood biomarkers do present a real opportunity for us to be able to have a better clinical pathway of management for people at risk of dementia, but we need more data. We need to think about where these blood tests would be done. Would they be done in primary care or secondary care? Would they be used as a screen for people referred to memory clinics? And how often would you need them? And we don't know the answer to that at the moment. If you've got a negative biomarker test, do you need it repeated in 3 years or 5 years? We just don't know. Is there a battery of tests that we need to do for people with symptoms? And what about people, as I said, in that really early stage before they start to develop symptoms? And maybe most importantly, how do we manage discussing the risks that people may have? If we say you have a positive biomarker test, we need to think how we're going to relay that information and discuss people's risks with them. And what does this mean for access to these new treatments? And what should be going in your medical records? So I know certainly in the US, there's a lot of concern that if your biomarker results were recorded in your medical records, that may mean you're less likely to be able to get health insurance. So there's lots of implications. And then there are other biomarkers in the pathway, so particularly focusing on genetic markers like ApoE4. There are these things called polygenic risk scores being developed, which looks at the probability of developing things like Alzheimer's disease based on multiple genetic markers. And again, there are commercially available tests already being developed, like cytox genus scores. And then there are other fluids that we're looking at in terms of biomarkers, and the deep and frequent phenotyping study I'm working on is trying to look at the utility of using things like saliva as a way of being a biomarker, and also things like retinal imaging. We know that a level of amyloid plaques is probably visible by retinal imaging, and that could be a very accessible biomarker if it just meant you had a photo taken in the optician, such as when you have your eye test, and that could give an indicator of your level of amyloid. And then finally, there are obviously digital biomarkers. And I know Great Minds is doing a lot of work in trying to gather data around these. And these includes what we would call active biomarkers, which you have to interact with. So things like games, tests that look at your speech patterns or the amount of electricity in your brain through EEG, or passive biomarkers that would look at your sleep patterns or your gait. And again, these could be really valuable in terms of early detection or tracking progress in response to treatments. And again, as we think about how clinical pathways are going to work, if you could go away with a device that allows you to either enter to do memory games or to be tracked in terms of your sleep or gait at home, that could really enable clinical management to be delivered in your own home and hopefully support longer term independence. And it allows us to collect a lot more data and maybe be more accessible for lots of people who can't get into clinics. But again, there are issues that we need to think about. What about privacy and data protection if you're uploading all of your data onto devices? How accessible are these devices for everybody to use, and how reliable are they? So overall, just to kind of finalize, in terms of the benefit of biomarkers, which, as I said, is an area of massive development at the moment, they're certainly very useful in terms of identifying people, particularly with early disease, what their level of risk is, maybe providing a more accurate diagnosis and prognosis, could be helpful for managing some of those risks and protective factors and providing motivation for people. They could provide a role in differentiating between symptoms people may be getting as a result of Alzheimer's disease versus other illnesses like depression or anxiety. If you were given information on your biomarker status, it may enable you to be much more proactive about making decisions about your long-term care or needs. And they are being used already as screening tools for clinical trials. And I think in the future, in the very not too distant future, we will be using them to create this very personalized approach to disease modification, predict response to treatments, and also adverse events. So I'm going to touch on now a little bit about other drug targets in Alzheimer's disease. Bob Barber has already talked about 2 drugs that are currently being developed and licensed in the US. I'm going to talk about a couple of more areas of interest. So amyloid and the accumulation of amyloid plaques is a key target, as is tau, as I mentioned, are things like inflammation in the pathway and how cells like microglia respond to that. This very busy slide highlights a paper published, comes from a paper published this year that highlights the number of drugs in clinical development over the last year. And you can see this is very, very busy. There are lots of things being developed at the moment. And what's interesting is if you look at this circle, on the outer part of the circle are the phase 1, so what we call the early phase trials. So this is when drugs are first being investigated, through to phase 3, which are the trials in the center of this diagram, where drugs are, we've got a lot of information that they seem to work and they're getting close to being licensed and available to the public. And you can see there's a pretty even spread. So what that tells us is that we have drugs now like donanemab and lecanemab that are starting to be licensed, but there's a lot more behind them in the pathway. And over the last 5 years, we've also seen a much wider spread of the type of drug. So you can see again on the outside of this circle, these drugs are drugs that modify diseases, enhance cognition in different ways, manage neuropsychiatric treatments, and so on. There is definitely more of a focus on drugs for earlier disease and an increasing use of biomarkers to identify if people are suitable for the drugs and if they're responding to the drugs. Another thing that's interesting is we're starting to see more repurposed drugs. So drugs that have maybe been used for a different condition like diabetes and may have a benefit in Alzheimer's disease. And ultimately, I think what we're also recognizing is a combination of drugs is ultimately going to be the way that we have most fruitful treatment for patients. So Bob has already talked about aducanumab and lecanemab, so I'm not going to dwell on these, but what's exciting is they are the first disease-modifying drugs for Alzheimer's disease, and actually amongst the first DMTs for any neurodegenerative diseases. And they certainly seem to suggest that we have a better understanding of all of those complex processes in Alzheimer's disease than we once did. And we're now seeing better biomarkers to identify people at risk and getting better drugs coming through these pipelines. And again, I think Bob may have touched on this already, but lecanemab is currently going through review within the UK as to whether it will become licensed, and also consideration with NICE. As you know, NICE looks in the UK at the overall benefits, risks, and cost effectiveness. So we could be expecting a decision on this drug in the next year or so. Donanemab is a little bit further behind. We're waiting on a decision of whether that becomes licensed in the US this year, but there are already trials going on to explore whether this could be used for primary prevention and also to compare drugs that are already available in the US. So is there one drug that's better over the next? So all of these drugs may have limited benefit in terms of the population they would help, in terms of the side effects that they may have, but it's such a massive first step. There is another drug called nataramag, which is in development. This is the third of those amyloid drugs. And the key thing about this drug is that it is delivered subcutaneously, so via an injection under the skin, so much more accessible than the other drugs that have been developed so far that have to be given by IV infusion. There are trials going on at the moment, including comparing different delivery methods, because again, in terms of how easily we can get these drugs to patients, that's going to be really key. And what's interesting about this drug is that it actually suggests it may be even better at clearing amyloid in the brain than donanemab. So people in the first trial seem to have a 75% amyloid clearance after 6 months, compared to 72% after 18 months with donanemab. So what this next slide demonstrates is, how do we know why these drugs work, and how does that help us develop better drugs in the future? So this diagram has put together the data from several of the trials of currently running trials of these drugs at the moment. To kind of explain what it shows is that basically the rate and degree of amyloid removal seems to really matter, and that people only seem to get actual clinical benefit from the drugs once the amyloid has been removed for long enough. So because we're seeing so many of these drugs come through these later phase trials now, we're really starting to understand what needs to happen in these drugs to make them work as effectively as possible. And therefore, what do the next stage of drugs need to look like? There are other targets. As I said, amyloid has been a key area of activity over the last few years, but there are a lot of drugs being developed to target tau. Now, as I said earlier, tau is an interesting target because levels of tau in the brain seem to correlate much more closely with cognition, and they seem to have a key role in mediating the impact of amyloid in the brain. So there are multiple drugs in early phase trials, including what we call passive immunotherapy trials, which mirror the way that the drugs like lecanemab already work. Another area that's really interesting is gene therapy. So there are a number of drugs being developed to look at how we target the production of things like tau by binding to key genetic things like mRNA to reduce production of tau in the first place. And there's already been quite dramatic successes in other neurodegenerative diseases with this type of approach. And then a third area that's being focused on at the moment is inflammation. This is a little bit further behind the curve in terms of drug development, but I think what we will see in the future is that we will ultimately be offering patients drugs to target amyloid, tau, and potentially things like inflammation as well as drugs for specific symptoms. So just coming on to the practical, I know again Bob touched on this a little bit, but how are we actually going to be able to deliver these drugs? Now, this is a diagram from the paper that's a couple of years old, where it basically demonstrates what the clinical pathway in memory clinics should look like now. And there's a lot of stuff on here, but just to highlight, you can see this kind of stepwise pathway on the top of the diagram that suggests you come into a memory clinic, you have a history taken about your problems, you have a blood test, a physical examination, you do some cognitive tests, you'll have a brain scan, and then possibly biomarkers and go on to management. And I would argue that for a lot of clinical services, this is still a little way off the mark of what we're able to deliver. And in fact, there was a study done a few years ago now that looked at how prepared we are across countries to deliver disease-modifying drugs. And they used a simulation model to assess how prepared certain countries were, like France, Germany, Italy, Spain, Sweden, and the UK. This was based on the idea that we would have disease-modifying drugs in 2020. And you can see that based on this model, they highlighted the first time that there wouldn't be waiting lists for drugs would be 2042 in the UK. So it would literally take us 22 years to manage the backlog of people who needed to go on to these new drugs that already had underlying Alzheimer's disease. And why is that the case? Well, the ability for us to have specialists, psychiatrists, neurologists that can deliver these drugs is a big issue, as are the capacity to deliver treatments. So what's important is that this piece of research was based on having to deliver the drugs by IV infusion. So this again comes back to the question that if we can deliver these drugs in different ways, or if you could have them for a period of time and then they be stopped, that makes this much more deliverable. And we're also aware that there, as I said earlier, there are a lot of people with milder disease that we don't even see in clinics, and that just will add to the burden. So we definitely need a unified, I think, international approach to how we're going to deliver these drugs at scale. And this has been suggested as what the pathway could look like. Again, I'm not going to go into all the details, but it shifts that earlier pathway very slightly so that you would initially present to your doctor and say, okay, I'm concerned about my risk or of developing dementia or existing memory problems. You'd have things like a physical examination, cognitive tests, but then you would go on to have some screening with biomarkers. So things like measuring ApoE, doing things maybe like saliva or tear testing, retinal imaging, and only then would you need to go on and do things like PET scans or lumbar punctures to confirm your biomarker status and be eligible for drugs. This very, very complex picture just demonstrates that in a different way. So on the top of this diagram is a suggested new pathway where, again, you go through some initial detection with cognitive tests and you end up doing kind of simple biomarkers and what we would call confirmatory biomarkers, CSF and PET, before you have treatment. The reason I've put this slide on is because on the bottom, you can see that this is where there's a real role for things like digital technology. These could definitely, digital biomarkers could definitely be used to replace or augment some of these other biomarkers that may be much more difficult to deliver. So what are the challenges we're facing in terms of how to get this science into the clinic? Well, definitely the coverage and focus of services is limited, both for being able to deliver biomarkers, but also drugs. I do think digital devices provide a real opportunity for early detection and monitoring alongside blood biomarkers. So I think the combination of those two are going to be the things that we're really going to see infiltrating our clinical services in the next couple of years. And there's certainly already been published evidence that if you just do a brief cognitive test and have a blood-based biomarker in primary care, that can already start to reduce waiting lists to see a specialist by working out who actually has underlying disease or doesn't. I think telehealth, so actually using digital devices to talk to your doctor, could be essential. And the reality is, I think that a lot of people, when they're monitored in the early stages of disease, will still sit in primary care. So there's going to have to be a lot of coordination between our GPs and our secondary care clinics, and that could be delivered by telehealth, maybe having more remote meetings and so on. But I can't overemphasize how important the real world data is at the moment, and this is definitely lacking. We know that certain people in certain ethnic groups, certain age groups, socioeconomic groups are more at risk for comorbidities that increase your risk of Alzheimer's disease, as well as how some of these blood biomarkers, for instance, perform. So we desperately need to be doing more studies and more research to understand how these things perform in those groups of people. And this year there was a paper published that highlighted what needed to happen across Europe and what brain health services, they've been called, should look like. And you can see on the top hand right of this diagram, there's a suggestion that brain health services, so a kind of memory clinic that is geared more towards that earlier disease, should be focused on risk assessment, communication about risk, personalized prevention, and only then thinking about cognitive enhancement and treatment. But you'll see from the bottom of this slide, what's interesting is the timeline. So this paper, which was, as you can see, authored by a large number of people across Europe, has suggested that the pilot phase for brain health clinic type services will probably run up to about 2025 or so. And at that point, we will be seeing large scale deployment of this type of service change. And this is already going on in the UK. Again, I know Chineze has talked about what's going on locally in her service, but as you can see from this map, there's a lot of other services across the UK already developing brain health models. And they are called that because they are very much focusing on identification of earlier disease. So things like risk profiling, personalized risk management, and thinking about how we align services and research in real world populations. And again, this slide just highlights some of the different ways people are doing this. All of the services vary a little bit. We've got Chineze up on this slide. She's already talked about her specialization in FDG PET biomarkers. But Brain Health Scotland is very much focusing on a national change. Ross Dunn in Manchester is very much focused on personalised risk management. So every site has a slightly different model, but I think it will be interesting over the next couple of years to see how these develop and whether they get rolled out at a wider scale across the UK. So I'm going to finish at that point with the final message that I think we are at a very exciting time for all of us, where dementia treatment and management is changing. It's been a long time coming, but we're now at the point where we can see a point where we could start to prevent dementia, which is amazing. But we need to get better at identifying people that are at risk and how we monitor their progress to treatments so that we can scale that up. And ultimately, scalable tests like digital biomarkers and blood tests will help that. But we have to be mindful of the fact that dementia is still, as a syndrome, very undetected. So across the world, it's still estimated about 60% of cases go undiagnosed. And the diagnosis of earlier disease is obviously even worse, so still very much an exception. So we've got a long way to go. And as we change clinical pathways, we really do need to think about the real world and diversity and inclusion and how we bring people in with different backgrounds, different health needs and so on. And I personally think what we really need to be doing is a very unified approach internationally, but certainly nationally, and pulling in regulators for drugs, drug companies who produce the drugs, policymakers, clinicians, patients, and the public. And I think we should be having more of an open conversation about where we all think these services need to go and should go over the next few years. I'm going to stop there. And I think at this point, Ivan, we are opening up to general questions.
Thank you very much, Vanessa. We've run over time quite a lot, but it's great to hear all the wonderful content that the speakers have given us. We've probably got time for a couple of specific questions for Vanessa, if there are any. Just while people in the room are thinking, one, Vanessa, you've talked quite a lot about cognitive tests. How accurate are these tests, such as MMSE, MOCA, SAGE, ACE, etc.?
Yeah, I mean, I think it depends at what stage of the disease you're using them, I guess. I mean, when people are starting to develop with present with early memory problems, they can really be very accurate at differentiating people who you think may have very early dementia, for instance, or not. I think as soon as you move into those earlier phases with milder disease, then it becomes much more difficult to pick people up accurately. And that's where we need probably to think about combination of biomarkers, so things like blood used as an addition to cognitive tests.
Okay, in which case we'll go through to the panel session. So on the panel, we've got Chineze and Ollie here in the room. We've got Bob and Vanessa on the screen. Obviously, we've got Steve here as well, if there are any questions. We haven't got too long, but we're happy to take any questions. So has anybody got any particular questions here in the room that they'd like to ask? There's one just here.
Hello. I've got peripheral neuropathy in my feet and Alzheimer's disease in my brain. And I've studied them both, and there seem so many similarities, but I can find no evidence of anybody doing any research into what 16 years of bad blood supply to your neurons has got, how much that compromises their ability to get rid of the amyloid. Do you know of any?
Anybody going to take that?
That's the response I usually get.
Chineze.
Yes, I suppose, is this one?
Yes.
Yeah, I don't know of any evidence for the two being connected, and I would differ to Bob and Vanessa really on this point. Bob, Vanessa, would you have any thoughts?
I mean, I was just going to say, Chineze, I guess in terms of diabetes, we know that there are certainly links between stages of diabetes and potential risk for Alzheimer's disease and progressing into dementia. So I think there are pieces, but I think diabetes, for instance, absolutely. I don't know, Bob, if you wanted to add anything to that.
And actually the drug which was mentioned right at the beginning of the talk today obviously is an anti-diabetic drug, isn't it? Which is, so there are shared mechanisms potentially between diabetes and Alzheimer's disease. But there's lots of research into vascular disease and how that affects brain functions and circulation. So there is a rich kind of evidence or research platform there for that area. Certainly small vessel disease, for example, where the smaller vessels of the brain are being affected, rather than those larger ones which lead to strokes.
Okay. There's been a lot of questions online about lifestyle interventions. So what kind of lifestyle interventions make a difference in the early stages?
So if I could start by saying that I think the main one is controlling your blood pressure. So having a well-controlled blood pressure will help to delay the progression of Alzheimer's disease and dementia in general. In addition, I think exercise, taking part in exercise 4 hours a week. And there's a recommendation it should be the type that brings a gentle perspiration to your brow. So there has to be a bit of effort. I wonder if Vanessa, Bob, would you add to that, please?
I mean, I think all of the things that we've seen highlighted through the Lancet Commission paper that I mentioned back in 2020, so things like managing any hearing loss, visual difficulties, we know is actually really key. Hearing loss was found to be one of the biggest modifiable risk factors in terms of dementia in that review. So, and we're still trying to understand the mechanism of that. There seems to be something about the fact that if your brain is requiring to spend extra time on understanding things because you're not hearing things effectively, that actually takes away from your ability to possibly deal with other very early cognitive problems. So I think the main thing, as you said, Chineze, is certainly physical exercise and managing your cardiovascular health, but also managing any perceptual difficulties like hearing, visual problems. Social activity, I think, is the other thing that we know has a great benefit very early on as well.
Yeah, and I think what's good for the heart is good for the brain, and vice versa. And I think in terms of, like you said, controlling blood pressure, cholesterol, activity levels, diet, and then smoking and alcohol, those sorts of things. I think the Lancet report is interesting because it talks about quite specific variables which might be pertinent to an individual, but also some very big variables like pollution, for example, or social isolation, which are slightly more difficult sometimes to tailor to the individual and know what the effect size would be of managing those sorts of changes. I think there's a move to sort of think about these being not powerful enough individually, but collectively where their strength might lie. So doing lots of little things might be where you get the most strength, and tailoring it to the individual. So personalizing from those different kind of option lists, if you like, the ones which are most relevant to you as an individual. And some of the things like genetics, of course, are very difficult to do anything about, or sex or age. So some are, there's a mixed bag there, I think, of ones you can do some things about, and other ones which we have to understand what their role might be, but difficult to change, I think.
We've got another question in the room.
First, I'd like to thank the panel for the information shared, but I want to apologize as well for what might be a very layman question. Has the business case been modeled that at a high level for the NHS justifies shifting funds to preventive care than post-treatment care? Does that exist at a high level?
Can I respond to that one? I think no is the simple answer. It's just starting to happen. So interestingly, certainly in England, NHS England has now started to float a change in the clinical pathway it's proposing to accommodate some of the drugs that Bob described. Part of that is looking at what's called the health economic benefit of different pathways. So as you said, can they quantify whether it makes economic sense to shift costs from current models of care to a different model of care? I think part of the problem is that a lot of the brain health clinics that I suggested have only really been running in the last couple of years. So trying to gather that data is limited, but certainly the clinic we have running in Oxford has started to quantify that type of data and has passed that data on to NHS England. So they are starting to look at this, but we're early stages. Part of the problem, of course, is that if you want to demonstrate that a change in clinical pathway is better for people who have dementia or maybe at risk of developing dementia, you really need to be able to demonstrate a cost benefit for over several years, because this isn't just about what happens to you over 6 months or 12 months. It's about what happens to you over the next 10, 20 years, probably, what you need in terms of healthcare, social support, a whole load of other things. So that's quite a long period and quite a lot of different data to pull together. But I think what's interesting is that after all of this kind of discussion over the last few years about these new drugs, we are finally saying we need to be able to make that case. But I'd have to say it's early days.
Thank you, Vanessa. Oh, sorry, go on. Go ahead, Bob. Sorry.
Well, the incidence of dementia is actually falling. So although more people are living to the period of time when they're at risk of dementia, that at that age, the risk of actually developing dementia is falling. And that might be lifestyle changes which are already taking place in people in their 40s and 50s. So there's some evidence that they may be pulling through already. But anecdotally, I understand what I hear in Scotland. I think that may be slightly more advanced, that relationship between public health, prevention, brain disease, brain health is a slightly more active agenda than it might be in other areas. I'm not so sure about Wales, if I'm honest, but I know in Scotland that's a very clear message, I think, that brain health depends on a whole range of different. We need to make brain health as such an important part of our lives as that it needs to figure much more significantly in politics and planning and so on.
I agree, Bob. And the other thing, just to comment on that about the incidence, is, as you said, in a lot of countries it is dropping, in a lot of countries it's increasing. And I think the sense is that a lot of those public health changes that are happening in certain countries are not happening in others. And there are also other changes, as you said, there's certain public health initiatives that are improving our overall health. So things like reduction in smoking, etc. But levels of obesity, for instance, are going up. So, you know, there's variation, I think. So if we think internationally how we're going to manage brain health in the future, that's why we're still looking at these overall set of numbers going up in terms of people affected by dementia.
Thank you. We've got another question online. Will these new treatments and biomarkers opportunities end up being a postcode lottery, or will they be made as standardised options for everyone across the UK? Vanessa, do you want to answer that?
I would very much hope they're not a postcode lottery. I think all of us here feel very strongly that these are such an opportunity in terms of being able to manage people's ultimate treatments better, but also focus them on people who really need them. You know, because part of the problem we have is how do we identify people at risk of dementia early on, and how do we identify people who aren't fortunately at risk? But, you know, I think the signs that people like NHS England are looking at how to develop services, and that includes using some of the new biomarkers, is positive, that this isn't going to be a postcode lottery and it isn't going to depend on your local area. It will be planned in a bigger way than that. But I think, again, we still have to wait and see. I don't know, Chineze, if you've got a thought from the Wales point of view.
Yes, actually, I do. I suppose nationally we have a dementia action plan, and our plan is being as managed by the Welsh government in a way that we have pilots that are being set up across health boards. And when these pilots are proven successful, then because of this equity issue, then we scale up. So the example is the FDG PET scanning that we piloted in Aneurin Bevan University Health Board. Now it's scaled up nationally. And I believe that there's an appetite within the Welsh Government to continue this approach, because actually everybody deserves the care. So that's our approach in Wales.
I do have a worry there will be a postcode effect, if that makes sense, because it depends on where you live, might affect your access to various aspects of this treatment. I do worry about that it's not going to be equally distributed if you live in certain communities which are poorer or more rural or unemployed and so on. I think there might be some challenges in terms of making sure that this treatment is actually equitable, actually. And if the past predicts the future, when the previous treatments came out in the late 90s, early 2000s, postcode lottery was a big issue. So I don't know. I hope we've learned, and I hope this ways around that. But I do worry about that to some extent.
And I would agree with you, Bob, and I remember that time as well. I think the only thing I would say is that it definitely was a postcode lottery for a while, but because we finally had drugs that were licensed, it did start to shift care nationally. And then I remember distinctly, there was a lot of concern that that was not appropriate, and therefore services had to start thinking about how they would provide the drug universally. So I think, you know, in some ways, even if you have a drug available in certain geographical areas, it pushes all the other areas to realize we need to be able to provide it for patients, or provide access for patients as well.
Ollie, go.
Sorry. I think just to add with some reassurance you've had in Wales is, but I do think this is higher on the agenda than it's previously been. There has been scrutiny in the Senedd around health inequalities. And I think it's largely because we have made mistakes in the health service in the past in Wales when it comes to things like Welsh language, delivering of dementia diagnosis or diagnosis across healthcare as well. So I think where those services are located in terms of equity, I think is really, really important. But I feel that's understood, but from a place of sometimes we haven't got this right in the past.
Another question in the room.
This sort of moves on really from what you were saying. The PET scans, they're not routinely used currently within the memory assessment clinics. And I'm just wondering, how available are they? Are they in every health board? And what are the criteria that people would need to get that? Because they're very expensive, and they, you know, so I'm just wondering what the criteria is and the availability of them. And is it a postcode lottery again?
I think it's a very good question. I think PET scans are supposed to be available nationally. Currently, the PET scans are being done regularly when indicated in an Iron Bevan University Health Board. They're being carried out in University Hospital Wales. I know that Powys Health Board, Cardiff and Vale Health Board also have been referring for PET scans. There are some difficulties in actually getting the pathway up and running. So I think in North Wales, maybe there's not the specialists who can read the scans available there. But there's efforts that are being made to make sure that people receive these scans when they need them. It's not every patient who comes for a diagnosis of Alzheimer's disease or memory problems that needs a PET scan. So not every patient should expect to get one. But when they're indicated, patients do get them, at least in an Iron Bevan.
I think it's a big issue, actually. There's only about 80 or so PET scans, or 80 to 90 in the country, I think, across the UK. So access will be limited. Not all those are working at the same time, etc. And the commissioning and the funding for those scans is controlled nationally. So the tariffs and so on are quite difficult to leverage. They're used a lot in oncology, but very little in mental health and psychiatry, unfortunately. I suspect there's very, very few people currently across the UK actually having clinical PET amyloid scans. Maybe that CSF biomarkers, taking a lumbar puncture, is going to be the scalable option here, and it does give you more information, arguably, and it's a lot cheaper, and it can be done in every district general hospital potentially. But again, Vanessa might know more about this than me, but I think there's only one centre in the UK where there's a laboratory available to actually process the lumbar puncture CSF. She's based in London. So we have quite a limited resource. It reminds me of the microchip problem when there's a fire in a certain factory that, you know, we're a bit vulnerable to everything going down a little bit. There seems to be only one centre available to do those analyses as well, which seems quite a limited infrastructure. Is that true? Is there more than one?
It absolutely is, but it is shifting. So I know I mentioned on my slides Manchester as a site that are developing capacity to do local testing for lumbar punctures. And in fact, one of the things that DPUK is involved in is setting up a project across some of our clinical sites to increase capacity to do CSF, including the analysis. So I think that we're very mindful of the fact that we can't, as you say, sit with one centre. the PET stuff is harder to solve. And I think what's interesting, as I said, is NHS England are looking up PET capacity across the UK, because obviously for the new drugs at the moment, there is a requirement that you would have follow-up PET scans, because although CSF testing is great, it doesn't necessarily show regional changes within the brain in the same way PET scans can. And my understanding, unfortunately, is the UK is fairly low on the table of countries internationally in terms of our PET scanner capacity. So we do have a long way to go to address that. But I think this is where the other biomarkers, the combination of things like blood, CSF, other biomarkers, that maybe in a few years, I think the sense is will replace some of the need for PET imaging. So in other words, there's definitely a gap at the moment, but what we don't want to do is to put all of our resources into increasing PET imaging, and then in a few years, other biomarkers actually become just as useful.
Is it 150 to 200 pounds to do a analyze a CSF specimen? I don't know. It's not.
It's £300. Yeah, for a full panel, and then to compare with the PET scan, which is £800, and an amyloid PET is 2,000.
But again, I think as we start to develop more centres that can do this, and we have more people doing the tests, you can start to bring down costs, because I think a lot of the costs with that is, as you said, if you have an entire panel and you only have so many samples to run, if you increase volume, like lots of things, you start to bring down costs. So it's a bit of a chicken and egg thing at the moment.
We are considerably over time, so I think we'll make this the last question.
Thank you. It's a question for Chineze. I was particularly interested in the home-based memory rehab service you mentioned that was run by OTs. I was just wondering if that is unique to the Ynair and Bevan Health Board, or if the other health boards in Wales have them, specifically Cardiff and Vale. Thank you.
I'm just struggling to see if my OT colleagues have the answer. I do know that in Cwmtaf Health Board, they do have an OT home-based rehab service, I think. And I think in Edinburgh as well, there is, in Scotland, they also have this service. What I know is that it's proving very, very popular with our patients with mild cognitive impairment. And actually, when people are diagnosed with mild cognitive impairment, it's helpful for them to have something that makes a difference in a practical way. And that's what we keep hearing back from our patients. Yes, thank you. Yes, hopefully it will spread as well. Thank you.
Okay. Apologies for running over time, but I think it's been a really interesting meeting and lots of interesting questions. I'll just finish on one point from me before I pass over to Chineze to wrap up. But just one comment online. I'd like to echo. Steve is so brave. I think it's great that he's able to prepare his discuss his dementia. So thank you very much for that. Thank you to all the speakers. I'll pass over to Chineze for a summary.
Thanks very much for joining us today. I think it's been a very interesting session, and it's been a pleasure actually to be here in person with yourselves, and thanks for those of you who joined us online. I'd like to say, as was already mentioned, special thanks to Maria and Steve again for coming to join us and sharing your experience. It's made this more important that we heard from yourselves. The other thing I'd like to say is thank you to our speakers, Bob and Vanessa and Ollie. Thanks very much for helping us to make this day very special. Simon and Steve and Rod, you've been behind the scenes, but without your help, it wouldn't have come together as well. I'd like to say, as everyone has already seen, that this is a special time for us in dementia. Those of us who work in dementia, people who live with dementia. It's a time that we should pull together to see if we can make things work better for our patients as well as ourselves as clinicians. So thank you for coming. And safe journey.